بسم الله الرحمن الرحيم. A hot topic. This is the acute pelvic pain. What is the imaging approach of acute pelvic pain? I think all of us are confronted with a case of acute pelvic pain in a female in the emergency department, and we have to think out what it could be. Acute pelvic pain is one of the most common clinical problems in women presenting to the emergency department. What is the acute pelvic pain? It is defined as non-cyclic pain in the lower abdomen or pelvis lasting less than 3 months. So, the acute pelvic pain can be long-standing, not acute at the moment. It may be lasting more than 3 months, less than 3 months. The differential diagnoses include gynecological conditions, and this is the gynecological organs that may cause acute pain. Urologic symptoms, musculoskeletal, sometimes the muscles may be spastic, causing pelvic pain. Gastrointestinal mainly the appendix, but there may be terminal ileitis or something related to GIT, vascular causes and metabolic causes. Diagnosis of pelvic pain in women can be challenging because many symptoms and signs are insensitive and non-specific. As the first priority, urgent life-threatening conditions. We must exclude first urgent life-threatening conditions like ectopic pregnancy, appendicitis, and ruptured ovarian cyst. And then fertility-threatening conditions like pelvic inflammatory disease and ovarian torsion. So this is the most important in our diagnosis. A careful history taking should be first we have a careful history taking, focusing on the pain characteristics, review of symptoms, gynecological, sexual, social history, in addition to the physical examination that helps to narrow the differential diagnosis. Of course, ultrasound is the primary imaging modality of choice. We first the transabdominal ultrasound, followed by transvaginal ultrasound, and Doppler is mandatory in all acute gynecological conditions. Women in the childbearing age with acute pelvic pain. In women especially, we have prepubertal group, and we have childbearing age group, and we have the postmenopausal age group. Each of them differs. In women in the childbearing age with acute pelvic pain, we must have history, physical examination, and most important is the pregnancy test. We must do pregnancy test. If she's pregnant, then we could think of ectopic. We can do quantitative beta HCG level and transvaginal sonography with color Doppler. If she's not pregnant, then this is the ectopic. If she's not pregnant, we start to think of other causes. But first, exclude pregnancy. This is many types of ectopic pregnancy will be seen in other lectures as first trimester disorders of pregnancy. Here is the different sites of ectopic pregnancy that we could search for. Not only the tubal, which is the most common is the tubal pregnancy in about 90% of cases, but we have many other sites like interstitial pregnancy, ovarian, intramural pregnancy, the most common abdominal pregnancy. So we have to search on all sites of ectopic pregnancy. Acquainted with the imaging appearance, how to suspect ectopic pregnancy? We have specific features for ectopic pregnancy that we can find a living embryo in the adnexal region. And there is non-specific features, and these non-specific features must be correlated with the beta HCG level. Like when we found an empty uterus. An empty uterus means that either the pregnancy is expelled out or there is ectopic present and we could not see it. So we must correlate with the beta HCG level. The most common that we found an adnexal mass, and this adnexal mass usually is seen juxta-ovarian because most ectopic occurs in the ampullary part of the fallopian tube, pseudogestational sac of ectopic pregnancy, particulate ascites, and ectopic tubal ring. This is a case specific to ectopic pregnancy. Here we have, there is a corpus luteum in the left ovary, and beside it there is a dilated fallopian tube with a fetal node inside. And this fetal node is viable, and there is umbilical cord, and this is viable fetal node within the dilated fallopian tube. So this is a sure evidence. In here, we didn't say suspected ectopic, we say that it is ectopic pregnancy present, non-disrupted ectopic present in the fallopian tube. This is another case. Here is the ovary, and this is what I just say to you. This is a juxta-ovarian mass, usually echogenic in appearance, with gestational sac-like inside, and there is high surrounding vascularity, fire of ring appearance, and this is the most common appearance of ectopic pregnancy. This is another case with missed IUD. She's 6 weeks missed period, and here the loop is seen traversing the ovary. Empty uterus, thick endometrium, and the loop is seen traversing the ovary, but unfortunately she has ectopic pregnancy on the other side. So this is missed IUD with ectopic pregnancy. So this is regarding the ultrasound. So does the MRI has a role in early diagnosis of ectopic pregnancy? The characteristic MR features of ectopic: gestational sac-like structure with 3 rings appearance on T2. 3 ring appearance on T2. يبقى gestational sac-like structures with 3 rings appearance on T2. Presence of solid component within the sac, which may be the fetal node. Presence of solid component within the sac. Dilatation of the affected tube. We may find dilated affected tube with hematosalpinx or tubal wall enhancement. This is dilated fallopian tube and enhancing lesions present here. Acute pain with pregnancy have many causes. Ultrasound and MRI are the preferred investigations because we tried not to do CT with pregnancy. Ultrasound remain the primary imaging modality of choice, and MRI help when ultrasound is inconclusive. If MRI cannot be performed, we can do low dose CT if we want to see stone in the ureter or something like that. And this is the key MRI signs of different acute pelvic abdominal pain with pregnancy. Some of them related to the pregnancy itself, like placental abruption, placenta percreta, and uterine rupture. This is related to the pregnancy, and this is a nice table. You can see the different imaging features. Like placental abruption, you will find subchorionic hematoma, and this subchorionic hematoma will be bright on T1 and bright on T2, and we restricted on diffusion. Placenta percreta, we found all signs of placenta percreta, like dark intraplacental bands and focal bulge, heterogeneity. Uterine rupture, myometrial defect, you will find myometrial defect in the case. Other signs that we have to enumerate: urolithiasis, appendicitis, bowel obstruction, hepatobiliary causes, and venous thrombosis. All that can be seen well on MRI. Pregnancy caused pain in early pregnancy again. In early pregnancy, less than 24 weeks, the pain may be just only due to ligament stretching, or the patient is about to have miscarriage. Molar pregnancy, because in molar pregnancy, when start expulsion and there is acute distension of the uterus, sometimes there is pain. Ectopic pregnancy, of course, and acute urinary retention in the early pregnancy sometimes occurred and cause pelvic pain. This is an abruption of the placenta, placental abruption, the premature separation of a normally implanted placenta. Here in the abruption, it is an acute angle with the edge of the placenta in order not to be, there is many pitfalls, to have serpiginous vessels underlying or something like that. And the patient may present by vaginal bleeding, and it is one of the causes of antepartum hemorrhage. So the patient can present by vaginal bleeding, abdominal pain, or both. A history of trauma or otherwise unexplained preterm labor. This is the abruption of the placenta. Here's the abruption with MRI. You can see here, there is detachment of the placenta with hematoma seen here. This is in T1 and on T2. In a non-pregnant female, you have to ask other questions. Pain and fever. If the patient has pain and fever, we always think of infection. So we have many tests like cervical motion. When you do cervical motion by vaginal probe, you find adnexal tenderness towards the adnexals affected. Or you have a point of tenderness on the affected placenta, on the affected adnexal region. So at that time, we can think of pelvic inflammatory disease or tubo-ovarian abscess. Like this case, this is a case of tubo-ovarian abscess. Note here, this is the dilated fallopian tube, and this is the ovary showing cystic collections, internal debris. This patient was feverish. She has intrauterine insemination just before by 2 weeks. So this is a sure diagnosis of tubo-ovarian abscess. Here, there is a role of CT in pelvic inflammatory disease. In early PID CT findings, we can show obscuration of the normal pelvic floor facial planes, thickening of the ligaments, cervicitis or oophorytis and salpingitis. We can see also accumulation of simple fluid in the endometrial cavity. Here, there is collection in the endometrial cavity or sign of endometritis. We can see also in the fallopian tube. You can see here there is a dilated serpiginous fallopian tube with ill definition of the fat planes and the thickened wall, which is seen with the tubo-ovarian complex or tubo-ovarian abscess. Regarding MRI also have a superior tissue contrast. MRI can distinguish hematosalpinx from biosalpinx and can differentiate tubo-ovarian abscess from possible ovarian neoplasm. Can tubo-ovarian abscess be misdiagnosed as ovarian neoplasm? Of course. If the tubo-ovarian abscess is some chronic, sometimes it can be diagnosed as borderline ovarian tumor or cystadenoma. So we have to do to ask for history of fever before, and we have many signs of differentiation we can say in another lecture. And we can detect also complications of the tubo-ovarian abscess and pelvic inflammatory disease, like pelvic abscess, like pseudoperitoneal cysts. All that can be detected on MRI. Pelvic mass on examination. If we have a pelvic mass, we have just said that the primary imaging modality is the ultrasound. This is by ultrasound. We have here a complex ovarian cyst. Here we have enlarged ovary, and this enlarged ovary is devoid of vasculature with Whirlpool sign, and this is characteristic to ovarian torsion. Here we have adnexal complex lesion, but related to the uterus, and this is a case of degenerated fibroid. So we have many causes that cause a complex adnexal lesion. We have to know it is ovarian or not, and start to know the origin of this complex ovarian lesion. This case, it is a complex ovarian cyst, but not here on Doppler, it is completely avascular. There is no solid vascular part, just follow-up. On follow-up on the 2nd month, there is nothing. There is complete resolution of this ovarian cyst, and there is a start new follicle here. So this is just a hemorrhagic cyst which completely disappear on follow-up. So if persistent, we need MRI for characterization. MRI will confirm the diagnosis of complex masses like endometriomas. It can confirm endometriomas and also diagnose deep infiltrating endometriosis either by the conventional MRI sequence or by the use of new MRI techniques like diffusion and the T2 star. Here the T2 star, we see here the signal void hemosiderin deposition in the wall of this endometrioma. So in all cases of suspected endometrioma, we have to do T2 star and susceptibility weighted imaging. Of course, endometrioma can cause acute pelvic pain and can be a source of chronic pelvic pain, both. And the use of diffusion weighted image. Usually endometrioma is restricted on diffusion due to the presence of blood products. But the hemorrhagic cyst being not persistent, usually not restricted on diffusion weighted images. MRI also can confirm and characterize ovarian torsion. This is a case of ovarian torsion. We can find enlarged edematous ovary. You can see the follicles spread in the periphery. We can find mild pelvic collection. Of course, this ovary have PCO, but no problem. Uterus is deviated to the other side, and here this is the left ovary. The left ovary is crossing the midline. So being crossing the midline, sometimes we found hemorrhagic on T1, no contrast enhancement on the post-contrast. These all features with diffusion, ovarian torsion. We will have a quiz case in the middle. This is a female, 38 years, and she's coming with pelvic pain and abdominal enlargement. And this is a cystic lesion. Most of the reports said that it is this cystic lesion, may be an ovarian cyst. But we did the false technique. CT in these cases are not specific. But however, if we do CT, we have to do sagittal and coronal reconstruction in order to see. This is the claw sign. This is the claw sign. So it originates from the uterus. Here is the uterus. This is the endometrium, and the myometrium is clawing around this cystic lesion. So this is uterine and not ovarian. So this is degenerated fibroid. But of course, CT is not the imaging modality of choice, but however, we can squeeze the CT to get the findings. On doing transvaginal complementary to CT, you find both ovaries are normal, completely normal, and we found that this cystic lesion is related to the fundus of the uterus here. And there is blood vessels. This is the bridging vessels that we see in MRI. This bridging vessels coming from the uterus to this cystic lesion. So this is a degenerated fibroid, and this is one of the causes of acute pelvic pain or in less than 3 months. Pedunculated degenerated fibroid. We have also the non-gynecological causes. The most common is the right lower quadrant pain migrating to the umbilicus with graded compression. We can find uniform pressure, gentle uniform pressure on the region of the interest, trying to find the appendix. Of course, it is a good positive but not good negative. If you find an inflamed appendix, it is a good positive, but if you don't find, you must correlate with the leukocytic count and follow up. And this is the normal appendix seen on ultrasound, blind-ended structure, and this is the layers of the appendix, and this is the base of the appendix with the cecum. So this is the normal appendix, and this is the target sign seen on TS of the appendix here. Of course, we are, if you can see, if it is pre-ileal, you can see it, but if it is retro-ileal or in an abnormal site, we could not detect. In appendicitis, ultrasound is not conclusive. We must correlate with the clinical and laboratory findings. CT is important in appendicitis if the appendix is in a typical site, being subhepatic or pre-ileal. Multi-slice CT with contrast is the most accurate imaging study for evaluating suspected acute appendicitis in cases of right lower quadrant pain. MRI also can detect appendicitis, better visualization of the abnormal appendix and the adjacent inflammatory process. This is the appendix on MRI, and there is adjacent inflammatory process seen. A visualization of the appendix in an abnormal location also, or a typical location. It is not operator dependent, and we can examine it in the obese patients. We can see the inflamed appendix on MRI. Also from the non-gynecological causes, the urinary related causes. Here, dysuria and hematuria. If the patient coming with dysuria and hematuria, there is here a cystocele and there is a stone in the lower end of the ureter, dilated ureter and stone in the lower end of the ureter. On CT also we can detect the stone here. So either ultrasound or CT, we can detect a stone in the lower end ureter causing pelvic pain. In the adolescent age group, don't forget to think about the obstructed uterine anomaly. This is a bladder, this patient coming with acute pain, and this is the bladder, and this is hematocolpus. This is hematocolpus, the vagina is distended with blood. So this is a hematocolpus needing further investigation to know if it is complex anomaly or just hematocolpus, the level of obstruction and all that. MRI, of course, we can see the level of obstruction. This is a hematocolpus extending to the perineum. So this is a case of imperforate hymen. If it is high up, we can detect if there is transverse vaginal septum. Again, this is a case of ovarian torsion. There is a cyst, and this is the ovary devoid of vascularity and markedly enlarged. So this cyst initiates ovarian torsion. So this is a case of ovarian torsion in adolescent age group. Common lesions are common, but don't miss the rare. Sometimes this is an acute condition. First time I think it's just a hematoma until I found that this term ovarian apoplexy, sudden ovarian rupture. You note here this is the ovary, and the ovary is ill-defined outline, rigid outline, and this is the appearance of a hematoma. Whorly appearance, there is no blood on color Doppler, so this is a large hematoma in the adnexal region. Usually it occurs following vigorous intercourse, and if you ask the patient about her sexual history, you found that there was intercourse at that time prior to this hematoma present. So this is a case of ovarian apoplexy, ruptured ovary. Also, don't disregard the patient complaint. If the patient has a special point of tenderness, you have to look by any approach by ultrasound, either by a deep approach or superficial approach if the point of tenderness is marked at that area. Here we have a hernial sac, but where this is hernial sac, it is inside the rectus muscle. This hernial sac is seen inside the rectus muscle. And this is a rare type of hernia named Spigelian hernia, and the patient usually has a severe point of tenderness at that point. Also, we can have, this is a young female, and she has hernia through the cesarean scar coming out through the abdomen, and she has tenderness at that point. So this is a herniated ovary above the cesarean scar site. So just let the patient point out the site of tenderness and have a look by superficial probe. Acute pelvic pain, we have to, good history is very important, clinical examination and laboratory. For example, in appendicitis, you must do leukocytic count and go to leukocytic count assessment. On ultrasound and color Doppler is the primary imaging modality. We can detect the source of pain by the ultrasound probe, and in pregnant female, of course, it will be very important. Limitations, it is operator dependent. This is very important. So please be careful during ultrasound examination. Use all ultrasound approach. Make the machine gain very important to set the gain of the machine in order to get a better diagnosis, because you are the first line. Operator dependence. Patient obesity, of course, is another limitation. If it is inconclusive and we need confirmation, or there is lack of characterization, so we need more confirmation by MRI in cases of endometriosis, for example. And if we want to know the extent of pathology, like other complications, deep pelvic abscess, deep infiltrating endometriosis, in these cases we have to go to proper selection of other technique. Cross-sectional imaging in MRI is appropriate sequence in pregnant female in tissue characterization in confirming ectopic torsion and obstructed uterine anomaly, and in cases of atypical appendicitis or appendicitis in atypical site. CT, either contrast or non-contrast, is needed in cases of inflammation, pelvic inflammatory disease or tubo-ovarian abscess, in cases of appendicitis and in suspected urinary stones. Thank you for listening, and I hope you could diagnose all cases of acute pelvic pain.